Welcome to Dinet Discussions. Today's session is a look at POTS subtypes with RN and our very own Dinet Forum moderator, Susanne Rimm. I'm Ellen Driscoll. I live with dysautonomia as well as other chronic illnesses, and I'm also the president of the board of directors of Dinet. My co-facilitator today is Lauren Malak, who is vice president of Dinet. Good morning, Lauren.
Good morning. So also joining us this morning, as Ellen mentioned, is Susanne. Susanne is a retired and disabled RN with more than 24 years experience in the medical field, giving her a very unique advantage to research the field of dysautonomia since her diagnosis of HyperPOTS in 2012. Since that, she has served as a moderator for Dinet's forums and has also written several articles for Dinet. And Susanne believes that despite the challenges of dysautonomia, that we can live a rich and rewarding life as long as we make peace with our limitations. Susanne, thank you so much for joining us today.
Hello, you're very welcome. I'm happy to be here.
That's a great philosophy. It definitely is something we all agree with for sure, about living a rich and rewarding life despite our challenges. So good for you. So first question for you is, can you explain for us how the autonomic nervous system functions in a healthy person and how that differs from the way it functions in a person with POTS, any form of POTS?
Yes, I will try my best. The autonomic nervous system is essentially mostly two parts, the two big nerve cords, if you want to call it that way, the sympathetic and the parasympathetic nervous system. Now, those would be more like the two main wires that go from the brain to the blood vessels, the gut, the heart, all the different things it regulates. It's called autonomic because it is not like the musculoskeletal system where I can say, make a fist, and I can tell the muscles what they want to do. Autonomic means it does that all on itself. I have no control over it. It affects heart rate, blood pressure, fluid household. It affects pupil dilation, urination, digestion. Most every organ or physical activity in our body is controlled by the autonomic nervous system. Now, there is an afferent limb that's called, it goes from the body to the central nervous system. So if it gets hot outside, that is something that comes from the outside and goes to the body. So then that's the limb, the part of the nervous system that goes back to the brain and says, hey, it's really hot outside there. The skin is saying, I'm too hot. What are we going to do about it? So then that would be like baroreceptors. Some people may have heard about that, and chemoreceptors, that are the receptors that react to certain chemicals that are released when the afferent limb receives a signal from the outside. Okay. To the body, and that is mostly, it goes from the skin or smell or whatever, noise, any senses, to the brainstem is where it is located. And then there's also the afferent limb, which is nerve fibers and autonomic ganglions, and that is essentially what then our body does, what our brainstem then tells the body to do. So, okay, it's hot. It goes up to the brain saying, it's really hot out here. What are we going to do? And then the efferent limb gives the signals to the body parts. For example, okay, we need to cool off, so we're going to sweat. We're going to start sweating now. Or if you get scared and the fight and flight will set in, that is the sympathetic part. It would says, we're in danger, what are we going to do? And all of these things are controlled, these reactions are controlled by the sympathetic and the parasympathetic nervous system. The sympathetic is the one that does the fight and flight. So in other words, if you go on a hike and there's a big bear comes charging you, then your body, you get so scared, your body dumps a lot of adrenaline or norepinephrine, and that is what the sympathetic nervous system does. It's the fight or flight. Am I going to run away, or am I going to try and fight this bear? And that means all of the circulation or the blood perfusion goes to the organs that are needed, or the body systems that are needed to either fight or run away. And that would be your muscles and your vision, your hearing, heart rate, of course, it's going to go up, because now you're like, now you're ready to fight or run away, and either one is scary. Then oftentimes, for example, why some people, if they get very scared, they may pee themselves, it will tell you, get rid of the pee, because we need to run.
If I saw a bear, that would be the first thing that would happen to me, for sure.
And of course, it will increase the blood pressure, increase the heart rate, increase the way we can perceive, concentrate. Everything gets more, we have stronger senses in this system. Now, the parasympathetic nervous system is the other, if you want to call it, nervous strand or cable, and that does the opposite. So instead of making everything hyper and sending all the circulation to the brain and the heart and all of that, what it does, it sends all of instead of fight and flight, it's the rest and digest. So it's like the after Thanksgiving meal slump reaction. You overeat, your body says, okay, now we're going to send all the blood and all the energy we have to that big overextended belly with all that turkey and sweet potatoes in it. And then you're going to go, oh, okay, now I'm going to just sit here and watch the game or something, because I can't move. And everything that the sympathetic nervous system would tell you, activate all of this, we got to run. Now it's like, okay, I'm not moving anywhere. I got to let this food settle in. So it's like essentially the opposite. And in a normal person, and I'm hoping people were able to get the gist of what these two parts do. Now, in a normal person or a normal body, these two nervous system parts will work off each other and with each other in perfect harmony. So, for example, when we stand up, gravity will naturally drop all your blood into your feet. That's called blood pooling. It can be in the feet, it can be in the abdomen. Gravity does that, but this happens in every person, POTS or no POTS. Then when we stand up and the blood drops into the lower part of the body, the autonomic nervous system senses that and says, oh no, now we have to do something to push the blood back up to the heart and the brain. So how it does that is by dumping out a little bit of norepinephrine, which is, in other words, adrenaline.
Right.
That's the part of the sympathetic nervous system that will make your blood vessels constrict so that it stops going down to the bottom. When they constrict, it stops it from falling down. Then, as the heart starts pumping faster, because if your blood vessels constrict and it stops dropping down, the faster the heart beats, the more the blood will go up to the heart and the brain. In addition to that, we have what's called the venous muscle pump, which is there's little valves in your veins, which are the part of your blood circulation system that pumps the blood, brings it back up to the heart. And those little pumps will start helping to pump it back up. So this happens in every person, every time we stand up. It usually takes less than a minute in a healthy person for this adjustment to take place every time we stand up. Now, most people know this feeling when you get up too fast, like you were maybe crouching down or sitting down a long time, the phone rings, you jump up and you go, whoo!
Oh, yeah.
Right.
And that is nothing to worry about. That is also a normal part of the body, because that just means we got up so fast that the autonomic nervous system couldn't catch up with all of the adjustments in time. That is nothing to worry about, but that can show you, that can give a healthy person, this example, a little idea of what happens to somebody when this whole concert of reactions and actions and this tandem concert of the autonomic nervous system reactions, when that is disturbed, all chaos can happen, because now all of a sudden your blood vessels, you stand up or you get scared, and now, for example, your blood vessels don't constrict. Instead of the sympathetic nervous system saying constrict, the sympathetic nervous system does not react. So now your blood vessels stay dilated, but your heart rate might start pumping real fast. What will that do? It will cause that you don't have enough circulation in your brain, that your heart has to work faster and harder, which then will cause your body to say, okay, now we have to put out more adrenaline. And it's just a tiny little thing that didn't work in this very well thought out, methodic chain reaction. One little thing does not work right, and the whole thing collapses.
Right.
And that is why, for example, the opposite can happen if your blood vessels constrict too much. For example, in hyperadrenergic POTS, your blood vessels constrict too much, and that will cause no circulation to the brain either, because now the hose is kinked essentially, and nothing can go up there, and that will cause the same symptoms, even though it was a completely different mechanism. It is so many steps are involved in the autonomic nervous system that any little step malfunctions and nothing works.
Well, it makes perfect sense then why people with dysautonomia are so sensitive to medications, how medications that, even over-the-counter medications that are very mild to the average person, can cause, as you said, chaos in our bodies, because it just disturbs, pushes us one direction or another and creates that kind of chaos. It makes perfect sense. So
Well,
you
I
touched,
can give you, I could give you an example there. For example, antihistamines,
Mhm.
they often can create chaos in an autonomic dysfunction person, because histamine is something that dilates the blood vessels. So if that's why we get rashes and we get hot in allergic reactions. We get flushed because it's vasodilators, all the blood vessels dilate. We get a swelling from an insect bite or hives from a food allergy. That's all due to the blood vessels expanding in reaction to, in response to histamine release. Now, antihistamines will constrict, they work against that, and they will constrict the blood vessels, which in some people can cause an unwanted reaction if their autonomic nervous system does not work correctly.
Mhm. I'm one of them. I can't take them at all. They make me very ill. Yeah. Okay, so now you touched on HyperPOTS. Can you explain to us the subtypes of POTS? Because that's years ago, it was all under one category of POTS, and they've since discovered that there's many different forms. Can you explain some of those, the major categories?
Sure. That's actually something that a lot of the doctors that are not very educated about POTS, they say POTS is POTS, and they throw it all into one category, and they all say, well, we're going to start with the beta blocker and midodrine or Florinef, and if they don't work, then it's all in your head. I'm not saying every doctor is like that, but because they're not having the understanding of the different types of different mechanisms that can be causing the dysfunction of the autonomic nervous system. So there's really currently 3 types that are accepted or recognized.
Mm-hmm.
The first one would be the hypovolemic POTS. What that means, it has to do with the fluid within the blood vessels. So the hypovolemic means you don't have enough fluid. That can be from being dehydrated, or it can mean that certain hormones are not functioning right. They would be called the RAS, renin, angiotensin, aldosterone systems. What that, it's the hormones that are released from the kidney, and they see how much is the kidney, how are the blood vessels in the kidney circulated, and if there's any problems there, it will send out hormones that either will make you retain salt and retain water, or pee out too much water. And water and salt always go together. So and it also, angiotensin, as the name means, angio means blood vessels, tensin, tense, it will make the blood vessels either constrict or dilate, depending on what is needed at the time. It's mostly about salt, water retention, reabsorption, and the vascular tone. So the tension of the blood vessel walls. All of this has to do with your fluid and blood pressure regulation in the body. So that a lot of times has that can be a cause for the hypovolemic POTS. But there is also another cause of it. You can, for example, they have found this in POTS patients, that I, for example, have it, the red blood cells are too large. So in other words, there may not be as many, or there can be plenty. It doesn't like have to give you an anemia or anything, but if the red blood cells are too large, then the volume in your blood in vessels is thicker. So you would need more fluids to, the thicker the fluid volume in your blood vessels is, the more pressure the heart has to pump. Right. And that can increase blood pressure and heart rate. So that is not in all POTS patients, but some POTS patients that can contribute to developing their symptoms. Another mechanism is the neuropathic POTS, and that has to do with, so the way we receive and bring information to and from our brain is by the nerves, and the nerves are like cables. They're all like this, a big stem of cables, and then little ones that go out, and at the end, where your blood vessel is, little tiny fibers of the autonomic nervous system go to the walls of your blood vessels, and those little fibers, they would be small fibers, they're called, they will tell your blood vessels whether they should dilate or constrict. And this signal comes through and from the autonomic nervous system. In some people, I know some people, they have those little small fibers, they're actually missing. So they don't have enough. So the signals don't get to the blood vessel walls strong enough. It can also be that in some of them, for example, certain diseases like Lyme disease or diabetes, a very big one, they can cause neuropathy in diabetes.
Right.
Diabetes, it's because if the blood sugar is too high, it can like kill off those nerve endings. And a lot of diabetics may have it in their feet only, but it can go to the autonomic nervous system also. And when those small nerve fibers that help giving the signals throughout the body, if they are malfunctioning or missing or diseased in any way, then the signals are not getting to where they need to be, and that can be a reason why people develop POTS symptoms. It's just a different mechanism.
Right.
And then there, of course, the third one is the hyperadrenergic, which this is a different mechanism altogether, because we said in the hypovolemic, it's what's within the blood vessels that triggers the autonomic nervous system. In neuropathic, it is the nerve endings that are supposed to tell the blood vessels to constrict or dilate. Now in the hyperadrenergic, it is the neurotransmitters, and those are, so you have the nerves, and the nerves go from, and it's like a knee. You have one nerve and another nerve, so your thigh and your calf, and there's the knee in between, the joint that holds them together. The synapse of the nerves is kind of like a knee. It brings two nerves together, and then in between the two bones, the thigh and the calf bone, there's space in between there, and there would be, in the nerve endings, there are neurotransmitters that take the signals from the one nerve ending to the other nerve ending. And those neurotransmitters are dopamine, epinephrine, norepinephrine, serotonin. Those are all neurotransmitters, and they are responsible for carrying the information from one nerve ending to the next nerve ending, so that the signal gets to where it needs to go. So in hyperadrenergic POTS, and the adrenergic part is the sympathetic part, the one that gives you the fight and flight, and it's like the one that gives you stress. And there are different reasons why there can be a dysfunction in the hyperadrenergic department. But one of the reasons, for example, is that your body just, when you stand up and your body says, okay, we need to put a little norepinephrine out so that the blood vessels constrict and the heart rate beats faster to pump the blood back up to the heart and brain. In normal people, that happens, and then as soon as the right blood pressure and heart rate has been established, then this excess adrenaline, if you want to call it that way, gets removed out of the synapse, so that we don't stand up and all of a sudden we go into shock because we have too much adrenaline. But in some people, and this is called the neurotransmitter, neurotransmitter hormone, and that is what NET, it's often called, and it's if that is like little Pac-Man, it goes and eats up all the extra adrenaline within that synapse or the knee between the two nerves. In some people, they don't have that little transporter hormone that comes and eats the excess adrenaline up, and therefore their body just constantly, once triggered, has a high level of adrenaline, and that causes typical symptoms of hyperadrenergic would be fast heart rate, high blood pressure. That's the difference between hyperadrenergic and the other types of POTS, because in the other types of POTS oftentimes do not have an increase or even drop in blood pressure. But in a hyperadrenergic, your blood pressure will go up because of this adrenaline, and you get cold hands and feet, cold tip of your nose, clammy skin, not sweating, but clammy, cold and clammy skin. Of course, you get a state of being hyper excited, not to be confused with anxiety, because in anxiety can cause symptoms close to what you might get in the fight and flight.
Right.
But in hyperadrenergic, you get the symptoms and they cause the anxiety, not the anxiety causing the symptoms. So obviously it can be very difficult for some doctors to decide what's the difference here. Other reasons why you could have hyperadrenergic POTS is genetic. In my family, for example, it is proven to be a genetic malfunction because it runs in the females of 3 generations of my family. And so it can be that, it can be your body just makes too much, instead of that the body doesn't, like the little transporter doesn't come and take away the excess. It's that your body just keeps dumping and dumping and dumping adrenaline once the ANS tells it to, and it just keeps dumping it. And that can actually cause people to go into essentially shock just because the phone rings or the pasta is overboiling on the stove, because they're, oh, I have to react right now, and the body dumps so much adrenaline out. So even within, as you can see, the neuropathic, hypervolemic, and hyperadrenergic, even within each one of those are little intricate variables that make it difficult to just say, okay, you have POTS.
Right.
And in oftentimes, for example, in neuropathic and hypovolemic POTS, the symptoms and the treatment are pretty much identical. However, in hyperadrenergic POTS, things that are the first medications that would help somebody with the other types, they would be contraindicated in hyperadrenergic. Same thing vice versa. Hyperadrenergic people often benefit from, for example, a calcium channel blocker, which is a medication that is there to dilate the blood vessels. Well, if you would give that to somebody with hypovolemic or neuropathic POTS, where the blood vessels are always too dilated already, then that wouldn't work.
Right.
So, and in hyperadrenergic, if you give them medications that constrict the blood vessels, which will help somebody with neuropathic or hypovolemic POTS, it would make it worse, way worse. So that probably those two, the hyperadrenergic and the other two, that is the most important differential that a clinician or a physician would have to make, is determine what is the underlying cause. Then another thing that I want to bring up now, these three types of POTS are the ones that are currently accepted, but there are two other things that I would like to mention. There's others too, but these two I am familiar with. There is an autoimmune component to developing POTS symptoms, and that would be the autoimmune autonomic ganglionopathy, or AAG they call it. And that essentially the autoimmune system can interrupt the flow of information throughout your autonomic nervous system. And in people like that, oftentimes steroids help, IVIG, which is immune globulin, and also any immunosuppressive drugs like hydroxychloroquine or other medicines that are used in like rheumatoid arthritis or Sjogren's syndrome, Lyme disease, all of these. And that, now this is just my understanding. There's not a study that I have read, but I believe that that is a factor behind long COVID or any POTS that you can get after a very bad viral infection, which Epstein-Barr can be one. The flu can give it to you. Any viral infection can essentially give you POTS symptoms, maybe not full-blown chronic POTS, but POTS symptoms. And that is because of the autoimmune part and the interaction of autoimmune reactions to with the how they influence the autonomic nervous system. Another one I would like to mention that can cause or worsen POTS is EDS, or hypermobile Ehlers-danlos syndrome, which is essentially when you have too much collagen in the joints, and it makes it like these people, oftentimes you can bend the thumb back, or they can like scratch their right nostril with their left toe or something like that. Those people have too much collagen, and it's as far as I know, that's genetic. And what happens with people with EDS, oftentimes they also have too much collagen in their blood vessel walls, which means if the collagen makes them more elastic, just like their joints. And so if you have, like, if you think you're putting water through a hose and you want a lot of water coming out at the other end, then that has to be a pretty stiff hose. Now, if the hose is rubbery and elastic, you would have the same thing as if you would take a water balloon and cut the end off, and you put water through there and it comes out in a trickle, because there's nothing. The water balloon would be too elastic. So there would be no pressure. And that is what can give people that have EDS POTS symptoms, and also people that have EDS and develop POTS would be affected worse by it. So and not every person that has EDS has POTS.
Right.
But if you have EDS, you are probably more prone to getting POTS. Actually, I read today in a study that 80% of EDS patients have a degree of POTS symptoms.
So let me ask you this, Suzanne. So in these three these three subtypes,
Yes.
they're all under the umbrella of POTS.
Yes.
But does that mean that everyone with POTS falls into one of those three categories? Or is there a general, I don't know, it sounds silly, but like a generalized POTS that doesn't fall in those categories?
Well, my autonomic specialist told me when I was first diagnosed, which was in 2012, that there's the bread and butter POTS, as they call it, which is typically found very common type of POTS. Oftentimes, this is what affects young people, or it's something that happens after a viral infection, after pregnancy, surgery, trauma, anything that puts stress on your body, you can develop POTS. And that is oftentimes mild and oftentimes transient, so it can get better. And usually, though, it comes and goes. But there's so many people that have POTS and they're perfectly functioning. Now, they have symptoms, but their bodies are able to compensate for them. Those are usually either the neuropathic or the hypovolemic.
Okay.
POTS. Now, you can function with hyperadrenergic too, but hyperadrenergic POTS is more rare because it's a different mechanism.
Right.
So currently, these three types of POTS are the ones that are accepted by the medical community. They're gonna want to put you in one of those three drawers. If you have POTS, if they even know about the differences, they're gonna want to have you in one of those. Neuropathic and hypovolemic, as I mentioned before, treatments are pretty much similar. Hyperadrenergic is different. So yes, currently, at current standards, if you have POTS, they're going to want to give you one of those mechanisms as a cause for your POTS.
All right, I have one question, although Ellen, you asked my other one.
Sorry.
No, you're good. Is there a certain way to go about finding which one you have? Like, is there specific testing for each? Because I have very stereotypical POTS. I got it young. It's been slowly getting better, but I still have symptoms, but it's very stereotypical. So it would be interesting to know how you go about differentiating the first two types to try to figure out which one you have.
Now, okay, that's a very good question. And yes, you can. I want to rephrase that. It is possible for somebody to test you and find out what is the cause for your POTS. It's possible, but in most cases, they can't. Now, neuropathic POTS, you can do a skin biopsy and find out if you have small fiber neuropathy, which is what I tried to tell you, the little nerve endings that you can do a skin test with that, but you may have neuropathic POTS and you don't have small fiber neuropathy. There's tests that a neurologist can do to determine that is not a skin biopsy, but again, it may or may not show something. Hypovolemic POTS is more difficult to determine because oftentimes people that have hypovolemic POTS, they have symptoms of being dehydrated, but they drink and they drink and they drink, but they may pee and pee and pee. And so in cases like that, that would be the RAS, the renin-angiotensin aldosterone system, that would kick in and make you either retain fluid, so it is in your like, let's say in your skin or in your tissue rather than in the blood vessels.
Right.
So you're retaining too much water, which gives you kind of dehydration within your blood vessels, or it can make you just pee out so much water that you can't even, the more you drink, the more you pee, and that can cause to like a state of dehydration also, which can give you symptoms. Now, in hypovolemic patients with hypovolemic POTS, the other types also, but especially hypovolemic, of course, drinking a lot of fluids, taking in a lot of salt, wearing compression garments that will compress your blood vessels with outside pressure, so that there is more pressure within your blood vessels. All of those can help for either one of the types of POTS. But hypovolemic POTS is difficult to prove because there's not really a way. You can do blood tests and they can give you essentially an idea how concentrated is your blood, and then they could say, okay, you need fluids. That can be done with a basic electrolyte panel. However, if that happens despite you drinking a lot, you will have POTS, and a lot of those people will benefit from IV fluids on an as needed or even regular schedule, but not it is not real. It is a proven quick fix for POTS, but it is not. They try not to order the IV fluids willy-nilly just because they know it's going to bring you around, because IV fluid infusions on a regular basis have their risks also. So most people, you're gonna want to drink a lot. Now, hyperadrenergic POTS, in order to determine that, you take a norepinephrine level. So your neurotransmitters get tested. I had that done. That's how my diagnosis was confirmed in 2012. And you have to sit down for half an hour, and they took several vials of blood, and then they wanted me, so I was in a completely relaxed state, so they check your base level of norepinephrine or adrenaline, and then they want you to stand up, walk around as fast as much as you can within a half an hour, and then you come back and they take your blood again, several vials, then to see how much did it increase the adrenaline level from being relaxed to being active. Normally, if it's up to 600, that would be a normal spike in adrenaline after being active. But anything over 600 is usually a diagnosis for hyperadrenergic POTS, that you have too much adrenaline, whether your body makes too much or it doesn't get cleaned out after you're done using it. In my case, it was in the 900s, and but I know people that have it like 12, 1300.
Oh, wow.
Adrenaline.
Oh,
And that's
must be
just after,
awful.
yes. And so that, yes, you can, but I would say none of the tests that they can do are going to be guaranteed, like, oh, yes, you have that type. A lot of it has to do, they have to, as always, listen very closely to when did it start, what were your symptoms, what is your family history, what is your medical history, what do you eat? How much do you drink? What is your work? You have to take the entire body, mind, and soul picture of a patient in consideration, because the autonomic nervous system deals with all of it. And it gets affected by your emotions, by your stress level, by your body, illness, surgery, everything plays into it. And that is a reason why oftentimes doctors don't want to touch it with a 10-foot pole, because it's so frustrating. It's so frustrating to determine what exactly is wrong. So I hope, did that answer your question, Lauren?
Yeah, it's really interesting that you mentioned the blood test, because shortly after I got diagnosed, when I was really sick and could barely walk, let alone stand, I had that blood test, but they didn't tell me what it was for.
That's the RAS or the RAS or the
the
adrenaline?
30-minute and 30-minute.
Okay, adrenaline. Mm-hmm.
And they had me lay down for 30 minutes, which was fine, and took my blood. And it was like, excuse me, like 10 vials. Okay. Which when you have low blood volume, even a few is a lot. And
yeah, you feel like you just gave a blood donation.
Right. So I remember that they then they told me after they did that, oh, well, we need you to walk around for 30 minutes. And I remember being like flabbergasted. I'm like, there's no way, I can barely stand for a few minutes. How am I supposed to do this? And I didn't understand that that's what they were testing for at the time. And I think they let me, I don't know if they let me sit up or stand for like 5 minutes. They had to modify it for me. And I got super sick and almost passed out afterwards. And it was a whole thing. But that's really interesting that I never realized. And this was probably right around 2010, 2012 as well. So I'll have to see if I can find those records to see what it was, but that's really fascinating.
I think I understand why it's frustrating for the medical community, because it is not something, anytime there's not a test that they can do that says yes, positive or negative, it's frustrating. But at the same time, there are, as a patient, there are so many different parts of all of these things that if you're reading about it, I mean, you know, obviously in my position, I read a lot about this subject, and on any given day, I can come up with 3 different ones that I think oh, that must be what's wrong with me. Because I was told by my doctor and my neurologist and cardiologist, we don't know what form of dysautonomia you have, but we know your ANS is dysfunctional, but we have no idea why or how or what it falls under. And that's frustrating for me and other people that are like that, because it's a crapshoot with what medication might set me off. Susanne knows I had an experience a couple of years ago where I was given a medication by my cardiologist that put me at a point where I was having pre-syncope episodes. I was back up to 15, 20 a day. I could not. I was so sick. And it was actually, Susanne helped me figure out that it was that medication when I went back to the cardiologist and said, I think this caused this. He read up on it, came back to me and said, oh, yeah, that's not a good one for you. So, yeah, we'll make sure. But he didn't consider it because there isn't any classic diagnosis for me other than this generalized dysautonomia, maybe dysreflexia, maybe this, maybe POTS, maybe, you know, so you really are shooting in the dark when you fall out of the range of these things. And there's no, like you said, Susanne, there's no specific test to say, yes, you're absolutely this. the consensus that my doctors have given is we try these different things, whatever seems to help you, we go with that, you know, but still,
Yes.
I mean, because they don't know what else to do. They're sincere. They're
Right.
not blowing
Yes.
me off. They're sincere. Okay, electrolytes help, salt helps. Let's do this. We won't give you blood pressure meds because that made you sick, you know.
Yes.
So they just play it by ear and try to get you to a level where you're managing your symptoms.
And that is because there is no standardized test. It would be so nice to go to the doctor and say, they say, okay, based on your tilt table, you have POTS because your heart rate went up, but let's just do this and this blood test, and then we can tell you exactly what you have, and then we can tell you exactly what medicines you can take.
Yes.
But that we're not there yet. We're not there yet. And I want to mention one thing too, is that POTS is only one part of dysautonomia, and as horrible as it is to have POTS, we that have a diagnosis for POTS, at least we're lucky in so far that we now have a diagnostic code that can tell us, okay, what you have is real.
Yeah.
And it exists. We have a number attached to it. But there's, for example, my sister who has everything I have and some other symptoms too that I thankfully don't suffer from, but she does not have tachycardia, which means the receptors with her that are responsible for increasing the heart rate are not affected. So, but she has everything else. She essentially has POTS without the tachycardia. But my sister lives in Germany. They are very much behind us with their studies of POTS, or not their studies, I would say their education of physicians with POTS. And she is disabled. She cannot work because of her autonomic neuropathy is what they have diagnosed her. And she did see a specialist here in the United States who gave her a diagnosis of autonomic dysfunction. He would have given her POTS, but she doesn't have tachycardia. So now in Germany, POTS is not really an accepted diagnosis. So therefore, she cannot get early retirement or disability over there because it is not something any insurance, even, you know, our equivalent to our Social Security, they don't, it doesn't exist what she has. So that plays into it too. So it is important that we get a diagnosis, but POTS or neurocardiogenic syncope, all of these can be tested with a tilt table test, for example. Not only you may have it and be negative at a tilt table, it's not the golden standard, but you can have the numbers match up so that you can get an accepted diagnosis. But if the numbers don't match up, you suffer just as much.
Right.
But you don't have a name for what you have. And oftentimes in those cases, these patients are in a very unfortunate situation that often they get told, it's in your head, you have anxiety because there's nothing we can find that's wrong with you. But they suffer just as much.
Exactly.
And their symptoms are real.
I'm glad that you mentioned the tilt table test, because I think that my experience in talking to a lot of people in the medical community, the ones who are not more aware of the different types of dysautonomia and the way, as you say, that the dysfunction is, the mechanisms are different in each of these cases. They tend to think of the tilt table test as the gold standard, not just for POTS, but for dysautonomia in general.
Mhm.
You know, if you don't react if you don't have a positive tilt table test, then you do not have any of this. And it must be, you know, it's anxiety, it's panic attacks, it's whatever. I have a negative tilt table test.
Hmm.
Yet on any given day, if I stand up and walk to the bathroom, I'm on the floor. So it just, you know, who can explain that? It depends, I think, in my case, I think it depends on how well hydrated I am, how much fluid I'm retaining. I think it has there's a lot of other factors that may not have been present on the day that they did tilt table tests.
And
And
that's
right.
exactly right, Ellen, because a lot of people, they have POTS, but they can have a tilt table on one day and pass it and have tilt table on another day. My first tilt table that was done in 2010 showed neurocardiogenic syncope because I actually did pass out. And that was what led me there in the first place, because I had so many syncopal episodes. And then in 2011, my cardiologist said, there's something else wrong with you. It's not only the syncope, because I had so many Holter monitors and they showed high blood pressure, high heart rate, all of these things. So he ordered another one. Unfortunately, my very, very good, compassionate, and knowledgeable cardiologist was unable to perform the tilt table test that he ordered. And it was actually an electrophysiologist who did the test. And after I had the test done, he told me that there's nothing wrong with me. The reason I think I have high blood pressure is because I take it too often, and that's because I'm a nurse. And I have anxiety, and my symptoms are all due to hysteria. And his daughter has the same thing, and she's just fine. And I told him, oh, well, that's easy for you to say, but I'm not allowed to drive because of all my passing out. And he said, you can drive. I will write that down for you. You can drive. And
Oh my gosh.
yes. And then that
Yeah.
electrophysiologist, a year later, I went to see my autonomic specialist, and he looked over the results of the second tilt table test that was deemed to be normal. And he said, this is clearly positive for POTS. And
Oh my God.
then he said, but he listened to me for 2.5 hours. I told him everything that had aspired to me and happened to me and all my symptoms and everything. And he looked over all the testing that had been done. He said, yeah, you have POTS. You have POTS. And that's when he did the adrenaline testing and confirmed that it was hyperadrenergic POTS. But you know, the difference between the electrophysiologist and my autonomic specialist is that my autonomic specialist saw me as a person, and he was aware of what the autonomic nervous system, how it operates and how a dysfunction affects us all. He gave me a list of like 30 symptoms, and he said to me, which one of those do you have? I said, well, I pretty much have all of them. And he said, that's what they all say, he told me. And he understands it. He understands it. And I am now, thanks to this doctor, that I no longer need to doctor with anymore, because he has me so well stabilized. I'm now can work with just my PCP and my local cardiologist, and I'm in a very good place. But all those doctors realize they don't label something that they don't understand as my fault.
Right.
They see, I see what you have is real, and let's see what we can do about it. Now there's a lot of trial and error involved in treating dysautonomia, and I had to try so many medications and treatments before I found the combo that works for me. I had to kiss a lot of frogs before I found my friend. And that is very frustrating, both for us patients as well as for the physicians.
Right.
But unfortunately, with the current state of research and what they and we know about it, it takes an effort on both sides, the patient and the doctor.
Well, and you're right. And I hear from people, I get emails from people all the time, and we get comments on YouTube, also complaining about the fact that POTS is the only one they ever hear of, that there's not a lot of information. I just had a woman earlier today that wrote about, she has NOH. And she was saying, you know, there's nothing out there about, nobody ever talks about what I have. There's no information for us. And, you know, that's very true too. It's, you know, it's wonderful that POTS has become a more familiar illness, disorder, and we still are nowhere near the education and awareness point that most of the medical community needs to have about POTS.
Right.
So we are decades away from the other forms of dysautonomia being more widespread and more researched, I guess, which is sad, very sad to me that we're that far away.
That is where I would like to bring in this analogy that I had spoken with both of you about before, about the well pump and the hose. So if people that live in a rural setting will know this. So you have a well, you dig a well, and then there's water in the well. You drop a pump in there, and you run electricity to that pump, and then you connect a hose to the pump, and the hose goes to the house and goes into your water heater or whatever. Well, if you turn on your water and nothing comes out, you can say, okay, our well is dry. And you can just say, that's it, we need to dig a new well. Or you can go and see what actually is it, and you call the well people, whatever they're called, and they come and they check, okay, the water tank is good and the hose is intact and the pump is working, but oh, I see the power supply where the power cable attaches to the well pump is rusted out and there's no power going to it. So I'm going to replace that. Then they replace it and you turn on the faucet, there's beautiful water coming out. So that's sometimes the way some doctors approach it. Okay, no water's coming out, we got to get a new pump. But that's only because they don't know how to search for what can be the reason.
All the other pieces, right?
Yeah.
So that analogy I always like to use to explain to people how many steps can be, how many problems there can be, the cause of the problem, how many things it could be, the hose, the wire, the pump, the well, the faucet, but you can't just say I need a new well, and that's where we need to find out more, and where doctors have to be more open to trying to find out what exactly is the problem here, so we can fix it if we can.
Right, because I think a lot of doctors have the approach that you treat. I believe that even Dr. Raj said this in a video presentation that he did for us, that sometimes you have to just treat the end symptom. In other words, if you're having problems with gastroparesis, or you're having trouble with any other intestinal thing, that then you don't necessarily need an autonomic specialist for that. What you need is a gastroenterologist to be able to
Right.
treat it, making that symptom better. It doesn't treat the dysautonomia, the POTS, whatever it is that you have, but it treats that end symptom. And that does make sense. Although I think, as I said before, I think the downside to that is that those other specialists that are treating the end symptom don't always know what medications are going to cause other symptoms that may be far worse than what you were dealing with originally. So I do think it's really difficult to have any form of treatment that doesn't come back to the ANS. You know, my husband has a transplanted kidney, a transplanted pancreas, as you guys know. And no matter what else happens to him, it could be a broken bone when he breaks his leg. The first thing we've been told to always do, the first person we call is his transplant doctor, because everything has to go through him. Any form of treatment, any drug they give him, anything, he has to be the front person that runs that interference, if you will, or that better partnership is a better way to think of it. And I think that's true with us too, even though I don't think we're at that point where they get involved unless it's something directly related to the dysautonomia.
Well, the good thing is, if we're lucky to have a doctor that is informed about dysautonomia and knows all the things we have tried and has a general idea about how our dysfunctional bodies react to medications, if we're lucky to have a doctor, whether it's a PCP, a cardiologist, neurologist, an autonomic specialist, doesn't matter, it's always best to run any medicines through that doctor. That's what I do. I used to run any medicine through my autonomic specialist. Now I run it through either my PCP or my cardiologist. If I go somewhere and I have to be on a steroid, I will run it through them first. And they try to not have me take them, but sometimes they have to decide, okay, we know it's going to give you really bad POTS symptoms, but the reason why you're taking it for, it's better you take it. And I will blindly follow their advice because I can trust them. Unfortunately, not all of us patients have good doctors available to them or have not found them yet. So in a case like that, I always feel if it's best, even it takes a long time, sometimes a year, sometimes a year and a half. Anybody that has uncontrolled or untreated or not sufficiently treated autonomic dysfunction, whether it's NOH, NCS, POTS, whatever it is, they should always, in my opinion, in my experience, seek the help of a specialized autonomic physician. Because if you do end up going to all these doctors, because autonomic dysfunction is a multifaceted condition, and if you go to all these doctors, all these specialists for all these different symptoms, you lose track of what's going on and who orders what and what medicine did what to me. And so anybody with autonomic dysfunction should have one physician that has the overview over everything.
Well,
so that's very good that you brought that up, Ellen.
Well, I honestly think, my personal opinion is, no matter what you have, whether it's Lyme or lupus or EDS, whatever you have, you need one doctor that takes a holistic approach to everything that's happening to you, regardless. And I think that's a good point. I know patients, people get very, very frustrated that they have to wait a year and a half to get into an autonomic specialist. And it is terrible that it does take that long. However, I agree with you, Suzanne, that it's really necessary to have that core diagnosis, at least to the point where, you know, my primary care physician knew about POTS, but didn't know about anything else. When she's actually the first person who ever brought a piece of paper to me and said, go to the cardiologist next time and show him this. And it was an article about POTS. It was the first time. In fact, when she first said, have you ever heard of POTS? I said, well, I used to smoke it in college. And she said, no, not that.
I love it.
So that's the first time I ever heard that
I love it.
But she, to her credit, has learned everything. She reads everything I bring her. She researches. If I have a question, if I have a symptom that doesn't seem to make sense, she researches it. She talks to other doctors and comes back with answers. And that's a wonderful thing. I think so. Even if you have a doctor that is compassionate and wants to help you, but doesn't know a lot, if they're willing to learn, they can be a wonderful advocate and support for you as well while you're waiting to see the autonomic specialist a year and a half from now. I mean, they can still help you. So is there anything you wanted to add, Suzanne? I learned a lot.
I did too.
A lot.
Not really, unless you have any more questions. I am a little long-winded here and there, but I hope I was able to get the point across from what I know about the questions you asked me.
Absolutely. Well, the one last question that I almost forgot was to ask about a predisposition to POTS. You mentioned genetics. Is there anything else that predisposes other than the primary illnesses that we talked about, like diabetes and EDS and certain illnesses that are more prone to POTS? Is there anything different about us, I guess?
These conditions, of course, can be the primary cause of your POTS, like diabetes, for example, or that can be the primary cause, but you can also get secondary POTS, which would be like you develop it because of a pregnancy or a trauma or COVID or something. And those would come, they have not yet really determined why certain people get POTS from either one of those pregnancy, trauma, virus or whatever, and some other people don't. So they have not really pinpointed or found out at all about why some people get it and some people don't. What we went over today are kind of what they know so far. The autoimmune, the, you know, the EDS, and essentially in my family, it is genetic. I do believe that there is a hereditary component to it in some cases, maybe in more cases than we realize. But whether that's genetic or just because in that family they're born with this neurotransmitter deficiency, you know, that I mentioned earlier, what exactly it is, it would be very hard to pinpoint, but I do believe that it runs in families, and it maybe not genetic, but like I said hereditary problem within that family. It is odd to me still that it is so much more prevalent in women than in men. At least the POTS NCS thing. Why that is, I'm not sure, but I'm assuming maybe it does have hormonal reasons too. I'm not sure. That's the problem. We are not sure. Nobody is sure at this point. There is no answers really, But yes, to answer your question again, I'm being long-winded. I believe there is a hereditary component, but nothing really, that to my knowledge, has come out of research that explains
Right.
it or pinpoints it.
Right. Yeah, I agree. I mean, that's just complete theory on my point, on my part, but I think there is a hereditary factor. Just like with autoimmune illnesses, there seems to be a pretty strong link between family members as well. But well, thank you very much, Susanne. It's been very informative. I really did learn a lot. I'll have to rewatch so that I can absorb more of what you had to say. I mean, for all these years and all the articles I've read, I still was foggy on the way the ANS systems
Yeah.
work, how they play into what's happening when I have symptoms, how that's happening. So it really, I'm sure everybody's going to learn a lot from what you had to say. So I appreciate you sharing.
It's the intricacy of the autonomic nervous system. It just shows us how amazing our bodies really are. I mean, when you simply consider, if I make a cut here now, it's going to scab over and heal itself without me doing anything. I can put a little betadine on it, but
Right.
that is amazing what our bodies can do. But it's also because of this amazing the amazing mechanisms that happen in our bodies. One thing goes wrong and the whole thing can collapse, and that's autonomic dysfunction.
That's right.
In a nutshell.
Yes, it is very much so. Well, thank you very much. I appreciate it. And anything else? Lauren, any other question that I missed?
I think we're good. Stay tuned for our upcoming videos. We have many more to come this month. And for more things dysautonomia, visit dinet.org. Thank you so much for watching, and thank you, Susanne.
Thank
You're
you.
welcome. Bye-bye.